Hi, my name is Eric Curtis, and I will be performing part 2 of my head-to-toe assessment for Nursing 383. I'll begin where I left off with part 1, and we'll be doing a neck assessment. We will assess the neck for symmetry side to side, noting any skin discolorations or lesions that are present, noticing the presence of any obvious masses or jugular vein distension. At this point, we will palpate the lymph nodes, and we'll start with the preauricular lymph nodes, and we'll assess them side to side, noticing any deviation from side to side. And we got the postauricular, and then on the other side, and we have the occipital lymph nodes on the posterior side of the head. Again, noting any swelling, any signs of tenderness, pain. We have the tonsillar lymph nodes, and again go side to side. Then we have the submaxillary on both sides, and then the submental lymph nodes. Again, noticing any deviation side to side, swelling side to side. Then we do the anterior cervical chain, and again on the other side. And then we can palpate the posterior cervical chain bilaterally. And then I'll have the patient shrug her shoulders, and we can palpate the supraclavicular lymph nodes above the clavicle on either side. Again, we're noticing for the presence of any inflammation, any pain that may be present in any of those lymph node chains. Moving forward, we will palpate the trachea on either side, noticing any presence of an enlarged thyroid gland, and noticing any deviation from that midline position. Moving forward, we will assess the upper extremities. Typically, the extremities would be exposed for direct visualization. We would be noting any changes in skin color, obvious masses, deformities, presence of any lesions. We'll move forward with palpation. We'll start at the acromioclavicular joint, move outward to the acromion process, locate the humeral head. We'll palpate around the anterior posterior aspect of the joint, moving down the upper arm to the elbow, and we can palpate the olecranon, the lateral and medial epicondyles, as well as the AC. Moving down the lower portion of the arm, we can palpate the ulnar head and the radius on the opposite side. We can inspect and palpate the dorsal side of the hand, fingers and joints, as well as the palmar surface. We will also perform that assessment on the opposite side, the acromioclavicular joint, out to the acromion process, and again locating the humeral head. Palpate both sides of the joint, moving down the upper arm to the elbow where we find the olecranon, the lateral medial epicondyles, and we palpate the AC. Moving down the lower portion of the arm to the ulnar head and the radius, and we can also inspect and palpate the dorsal part of the hand, fingers and knuckles, or finger joints rather, and the palmar surface. Again, watching the patient for any indicators non-verbally of pain or tenderness, such as grimacing or guarding, taking into account appropriate muscle mass, noting any atrophy that may be present. Moving forward, we will do some range of motion, testing the range of motion of the shoulders and the elbows. I'll just have her follow some movements that I do. We'll go up above the head, and then down around the front and cross. Okay, good. And we can come out in front, and we will adduct. Okay, good. Then we will abduct, and then we will come up behind our back, and then up behind our head. Okay, good. And then I will have her hold her arms straight out forward, and we will test some strength of the upper arms, so don't let me push against you. Don't let me pull. Don't let me push on your elbows. Don't let me push out. Okay, good. While she's here, we'll test the strength of the wrist, so from the wrist up, don't let me push against your fingers. Good. Don't let me pull. Good. And then we'll have her extend her hands out like this, and we will have her flex wrists down, extend wrists up, and rotation of the wrists. Make a fist. Open your fingers wide. Okay. Don't let me close. Okay, good. Close your fingers. Don't let me open. Okay, good. So range of motion is within defined limits. You can lower your arms. Thank you. Which we would score her a 5 out of 5 for range of motion. And to finish up with the upper extremity assessment, we will inspect the radial pulse. Again on both sides, checking for rate, rhythm, and quality, and any deviation in symmetry. Typical average pulse is a rating of +2. We will then inspect or palpate the brachial pulse on both sides. Again, noting any differences from side to side, and assessing that quality and rate and rhythm. We will then finish up by palpating the epitrochlear nodes that are just above the elbow, on the inner aspect of the arm, in the groove between the bicep and tricep. We were again palpating for the signs of any inflammation, any warmth, or any tenderness that may be elicited upon palpation. Typically those nodes are not palpable. That concludes our upper extremity assessment. So we'll move into the lungs and thorax portion of the assessment. So I will first observe her breathing, as she is breathing nice and easy, non-labored. There's no signs of any retractions, nasal flaring, chest rise and fall is symmetrical. So we will start with the posterior side, so I'll have her turn just a little bit for the camera. Typically the posterior would be exposed for direct visualization of the skin. And then we would begin by palpation. So we will palpate starting above the scapula from side to side, noting any tenderness, any deformities, any masses that may be present, and any pain or tenderness that may be elicited. We would also palpate for respiratory expansion. As I wrap my hands around the lower portion of her ribs, I'll have her take a deep breath in. And then I note my thumbs spread apart as she inhales, and then they return as she exhales, noting appropriate expansion. Following palpation, we would do percussion in the same manner, starting above the scapula. And we will percuss side to side, listening for that resonant sound as we percuss in between the intercostal spaces. From side to side, noting the symmetry or any changes thereof. We'll palpate, or percuss rather, the costovertebral angles, noting if there's any pain elicited at that point, indicating possible tenderness within either kidney. Also important to note, if percussion yields a dull sound, that may be an indicator of fluid accumulation or atelectasis. We would follow up on the posterior with auscultation, using the diaphragm of the stethoscope, again starting above the scapula, and we'll have the patient take a breath in and exhale. Okay, go ahead and breathe normal. So we listen on either side through one full respiratory cycle. I'll just, for sake of time, kind of click through here quickly. Listening side to side, typically from the top to the bottom, you would hear bronchovesicular sounds that become more vesicular as you reach the bases. And again, sounds of crackles do indicate presence of accumulation of fluid or atelectasis. So that concludes the posterior portion of our exam. So I'll have her turn towards the camera again a little bit. We'll then inspect the anterior portion. Again, anterior sides exposed as needed. Noting any color variations in the skin, presence of lesions. And we can also palpate respiratory expansion on the anterior surface as we did on the posterior, noting for expansion of my thumbs and then the return on exhalation. We can also palpate from side to side, starting above the clavicle on either side, noting any deviations from side to side, any pain that may be elicited, any deformities that are present. And we would palpate down and around underside of each breast. Following palpation, we then would auscultate, or percuss rather, and again listening for that resonant sound as we percuss in between the intercostal spaces. And again, listening for that resonant sound, we would percuss down and around underneath the breast tissue. And again, dull sounds indicate presence of fluid accumulation or atelectasis. Following that, we would then auscultate the anterior portion, again with the diaphragm of the stethoscope, starting above the clavicle for one full respiratory cycle with each auscultation. Auscultating side to side to detect any deviations in symmetry and breath sounds, diminished from one side to the other. As we listen, we go down and around underside of each breast. Important to note that the right middle lobe is only auscultated from the front. Therefore, it is critical to lift that breast tissue out of the way and auscultate that lobe anteriorly. That concludes our assessment of the lungs and thorax. Moving on to the cardiovascular portion of the exam, you will again take note of the neck, looking for any signs of pulsations, carotid pulsations. We will inspect the precordium, noting any heaves at the apex or pulsations of the apex. We will palpate the carotid pulse, only one side at a time, noting rate, rhythm, and quality, and avoiding palpation bilaterally at the same time to avoid any type of syncope in the patient. In the event of a thrill that's being palpated, one can auscultate for the presence of a bruit that may indicate a blockage of the carotid artery on one side or the other. Palpation of the precordium, we take an open hand, we lift that breast tissue out of the way, palpate with an open hand at about the 5th intercostal space for any pulsations that may be felt. You can also palpate across the base of the heart and the left sternal border, and again determining if there's any pulsations present. Following palpation, we would then auscultate the various areas of heart sounds, starting in the aortic valve area. We would listen for S1, S2 sounds. We would move to the pulmonic valve area, and we would go to Erb's point, where S1 and S2 are heard pretty equally. And then the tricuspid area, tricuspid valve, and then the mitral valve can be heard underneath the breast at the 5th intercostal space, mid-clavicular line. We would listen for the presence of any S3, S4 heart sounds, which are abnormal, presence of any clicks or murmurs. In the presence of a murmur, sometimes they can be heard better with the diaphragm of the stethoscope. So finishing up, it's important to note that the cardiovascular exam would be completed in 3 positions, one being the sitting or upright position, the other would be the patient leaning forward, and the final would be the patient in the left lateral position. So that concludes part 2 of the head-to-toe assessment for Nursing 383. Thank you.